2. Hello, everyone. I am so excited about today's presentation. I just want to say thank y'all so much for your incredible patience over the last couple of weeks. We've had some crazy things going on with the global outage with GoToWebinar, which is also the, or Citrix, which is the home company for GoToWebcast. And so we really appreciate you rescheduling today's presentation and being able to be here today. This is going to be some incredible information. I am so excited because my very good friend and mentor in the webinar world, Erin Reynolds, is the one who introduced me to Paul and Dr. Davini, who are going to be our presenters today. They have an incredible background when it comes to consulting with chiropractic offices in the areas of billing and practice management. They're doing some pretty incredible things to make your life easier, and you know I am all about that. Whatever we can do, that is our mission, whatever we can do to make your life easier at the front desk, your life easier as the doctor, and finding those people within this community in chiropractic who are doing that too, I am all about putting them in front of you and letting them shed a little bit of relief and bring some of that to your practice. So before we get started, you know the webinar is being recorded. You don't have to request it. It's going to be sent to you. Please submit your questions throughout the broadcast. We are going to start and stop on time out of respect for your time. If for any reason we do not get to your questions, I'm going to send those to Paul and to Dr. Davini, and we're going to get those answered, and I will email you back within by the end of the week. Let's be honest, it's a holiday week. It's a busy week. I'll get them to you by the end of the week, but we're going to do our best to get that done today. If you're like me and you think of a question 30 minutes after a webinar, you can email me and let me know what your question is, and I'll be sure to share it with them. So I'm going to shut up now. I'm going to turn it over to the experts, Paul, Dr. Davini. Thank you so much for being here today.
Thank you, Christy. We appreciate the opportunity. This is Paul Andrews.
And Mark Davini. Thank you.
And just a little bit
just a few words about ourselves. Yeah. Well, you can see from the slide there, I'm a practitioner, chiropractor, practiced over 25 years, very heavily into the regulatory aspects of regulation and lawmaking. Paul and I teamed up and started and formed Top Education and moved toward the compliance ends of things here. Massachusetts compliance has been mandated since 2005, so we have a lot of personal experience with it. So between my clinical expertise as well as my ongoing compliance and regulatory experiences, I also act as an expert witness on numerous occasions and have been in court many times. So we have a different perspective on not just practice, but all the issues that concerning practice. And with Paul, I'll let him speak for himself. We bring in a different perspective.
So starting out as a chiropractic assistant and then opening a chiropractic and physical therapy specific billing company back in 2002, consulting for chiropractors and physical therapists, and then joining forces with Dr. Davini with his background. We were two pieces of a puzzle that fit together to broadly and deeply help and assist chiropractic offices in pretty much any topic or endeavor that they need. So let's take a look at compliance, and this all relates into the topic at hand, which is about if you're fraudulent and don't know it. So compliance is not an option. It's required by the Office of Inspector General. Many states are adopting requirements from either their healthcare or their state regulatory board level. How you accomplish compliance is certainly an option, and one of the things that we offer, and you'll see as we get towards the end, is that we have a remote compliance officer assistant program for our members, and we help keep you in line and on track by assisting with an online compliance program and manual that you access via a private web page, and then monthly phone calls either fielded by you or one of your assistants, and those are to keep you on track with compliance, because compliance and a compliance program isn't one of those manuals that you have somebody make and then you put it on the shelf. It is a living, breathing program that intermingles with all aspects of practice, and it's meant to keep you up to date, keep you in line. And the way we approach it is to have an no paper, no hassle online approach that helps keep you on top of it.
So let's just jump right into the topic at hand here, and we're talking about fraud. And this has become a big topic across the country as more and more insurers are starting to look at the way we do things and taking a very aggressive approach toward it. So if we were to say what fraud typically includes, it would be knowingly submitting a false claim or making misrepresentations of fact. Now that seems to be logical, especially when you're dealing in the healthcare industry. It's knowingly soliciting, receiving, or offering and or paying remuneration to induce or reward referrals for items. So basically, if you own a company, you have different corporations, you have pieces of an MRI or whatever, and you're referring to them, and there's not any, if you don't have proper disclosure, that could be considered fraud. Making prohibited referrals to certain designated health services. Again, your wife or your husband owns a different company, maybe a vitamin shop or whatever, and you keep making referrals to that vitamin shop, and the patient doesn't understand that you are deriving profit from that connection. It says when somebody intentionally executes or attempts to execute a scheme to obtain money or property of any healthcare benefit program. And that's really what we're talking about here, is that you are doing something. The main reason why you're doing it is because you want to get reimbursed. Be mindful that the Office of Inspector General does understand the difference between innocent acts and reckless or intentional behavior. So that seems to be the key there, reckless or intentional behavior.
And then we take a look at abuse. And abuse is delineated a bit differently, and this is really when you talk about practice, direct or indirect, that results in unnecessary costs. It could be something that's inconsistent with recognized standards, and we'll put that in quotes. Some examples would be billing for something that was unnecessary from a medical standpoint, something that was excessive, or even a misuse of coding, such as upcoding or bundling codes, and we're going to go into some examples of that as we move forward. And you do have a liability exposure here as a provider, both civilly and criminally, so keep that in mind. And then we talk about waste, and waste in most cases, it's not caused by something reckless, but rather a misuse of resources. Again, ordering something that may be an unnecessary test or a redundant test, things that become, as the definition implies, wasteful.
Yeah. The biggest difference between fraud and waste is the intent. A lot of times they may seem like the same activity, but it's the intention that seems to make the difference.
When we look at some examples, and we're going to take a closer look at some of these to reflect what might be unintentional on a provider's or office's part, but we see sometimes commonly in our work with our offices, our member offices, with compliance and bill reviews and other documentation reviews. Upcoding, that's pretty straightforward. You're upcoding a claim for services that were more than what you provided. We might typically see that in exam levels or sometimes reporting more regions than were actually adjusted. Cloning. Now in EHR software, you automatically are generating a falsely detailed note. Those recurring or same as last time buttons can get you in trouble if you're not reviewing that salted note and making sure that you've made the changes that you need for today's specific visit. Phantom billing. This is billing for a service that was never performed. Now, phantom billing, it could imply that's 100% intentional, but again, with recurring or same as last time EHR records, sometimes an exam that you did last visit, you salted over today's visit and forgot to remove it. And So all of a sudden you're billing out for exams 3 and 4 times and then in every visit, and they were never performed. Services unbundling or fragmentation, again, multiple procedural procedures that separately could be billed, but when you put them together, there's a bundling that happens, and oftentimes you'll see insurance carriers automatically deny a particular CPT code as bundled service to something else. A very classic example in a lot of carriers' eyes is hot or cold pack gets bundled into a primary procedure. Self-referrals, talked about that. We'll talk about that some more. Repeat billing, standard of care. Now, billing for services in which the provider failed to meet standards of care. We'll go into a little bit of that. That can certainly run into clinical decision-making, but there are standards out there, and unnecessary when a provider performs unnecessary tests in order to bill for them.
So if we look at this slide, you can see it's more of a continuum because, again, the difference between what you might call an error and what somebody else might call fraud actually comes out to be, it could be intent, it could be procedure, it could be that you're not performing services the way that they're supposed to be performed. There's a lot of difference between going from the left end of this continuum where there's simple errors or mistakes become waste where it's just, you're just doing it very sloppily, and as a result of that, there's more money being billed or costs are being incurred that wouldn't necessarily have to be incurred. Abuse comes out to be where you just kind of stretch the truth a little bit. Those gray areas where the difference between fraud and abuse is if you're stretching it to the point where the sole reason why you're doing it is to get more money, then that becomes fraud. And so you really can talk about almost the same things from left to right, and a lot of it will have to do with your intent. The problem is that if you ever have to defend yourself, you may sit yourself in the left side of this continuum, and the people charging you may want to sit yourself in the right side of this continuum, and based upon your compliance, which we talked about a little bit, would determine whether or not a jury determines where along this continuum you really fall. So very simply, not all improper payments are fraud, but all payments made due to fraud schemes are improper. And Medicare has taken a very hardcore look at this. They have directed the Office of Inspector General to handle the chiropractic problem. Basically, if we look at the next slide, you'll see that there's a amount of fraud that is taking place, or we'll say at least errors taking place in the chiropractic profession is pretty extreme. So the Office of Inspector General said you have to take care of it. And I know you're sitting there thinking to yourself, is this if it's intentional and I didn't intend it, then it can't be fraud. Yes and no, because the choices you make are based upon the information you have. The information you have is supposed to be what you're supposed to know what you're supposed to know. All government agencies place it on you to learn what needs to be learned so that you do everything properly. So claiming I didn't know, claiming ignorance to the law is not a defense. So even though you technically might not have known what you were doing and not intended it to be fraudulent, they could interpret it as being fraudulent. Because remember, who makes the accusations? The accusations are made by the insurance companies or by government agencies like your state board. They are the ones that are making the accusations, and you have to defend yourself against them. So you sitting there saying, I didn't know I was supposed to follow the rules and regulations, that won't be a defense. So you knowing is just as important as is an important part of your defense, and saying that you don't know is not an acceptable defense. Again, if you look at the next slide, you can see chiropractors, and this goes back only to the beginning of last year, but our error was 100% when we last were examined by Medicare. This is what forced the Office of Inspector General to tell Medicare to deal with us. And because of that, you may have noticed more audits coming through. And those audits will be aggressive in their language. They won't just basically say, oh, we know you probably made a clerical error, or this is a they will be aggressive in claiming that you have committed fraud, and it will be up to you to prove otherwise.
So ask yourself, in light of all this, we have some questions, and we'll go over some of the specifics on it, but ask yourself, do I perform medically unnecessary services? Now, sometimes that isn't your point of view. It is the medical policy of the contracted carrier for which you have provided services to their members. Is it medically unnecessary in their eyes? Do I unbundle services? Are there duplicative or redundant services? You're performing, multiple modalities that are trying to achieve the same clinical outcome. Are you using your modifiers correctly? And we're going to go into some of those modifiers in a couple of slides from now. Do I regularly bill a level for a new patient exam or higher? Are you billing a higher code of exam than you're actually documenting that you're performing? And one of the major guidelines for documenting level of exam is the 1997 Evaluation of Management Services Guide from CMS. Believe it or not, it's getting old, but it's still one of the standards. Do you regularly bill a 98942? That's a 5-region chiropractic spinal manipulation. Are you billing for all 5 regions? Maybe your specific technique has you adjusting for all regions, but are you billing for it? And if you are, does your documentation correlate from chief complaint all the way down to plan, metrics, and clinical outcome and resolution? Do you regularly bill for an extra spinal or extremity chiropractic adjustment? Again, some of our techniques out there could have you doing that, but again, is the documentation correlating from chief complaint all the way through to treatment plan and then ultimately resolution in some way? Do you bill for a attended electric stim, but you're performing unattended electric stim? And we'll go into a delineation there in a few slides from now. Do you regularly bill therapeutic exercises? And if you do, is it being billed correctly? We'll go into the details of that. Do you bill regularly for neuromuscular reeducation, another code that we often find documentation to reflect either a different service or insufficient? Do you regularly bill for manual therapy techniques? And if you do, are you complying with AMA CPT guidelines and correct coding initiative edits on billing manual therapy techniques when an adjustment is performed on the same day? We're going to go into the details of that as well in a slide.
You also might ask yourself, do you upcode, which we talked about, using a code that is higher or represents a higher level of service than what you've actually performed. You also might ask yourself, do I bill for services not rendered? Now, that answer should really be no, but you'd be surprised sometimes the level of coding that you present to an insurer might actually be a higher level, which means you are billing for a service you didn't provide. You might ask, do I refer to other companies you own without disclosure, which we mentioned earlier? There has to be very distinct protocol for self-referral, if all, especially in the Medicare world. So if you don't understand the laws surrounding self-referral, then that would be a very dangerous place to be. Do I perform all the same services and charge the same fee for a self-pay? And really, isn't that what ChiroUSA is all about, is finding a way, a legal way, a better way to have a different fee for your self-pay patients? So there are different ways to do it, and there's really only one good way, and that's why we're a strong advocate of the services like ChiroUSA. Do I have a pattern? And that means, do all your patients get the same treatments? They get, no matter their age, their condition, what's wrong with them, how many problems they have, whether the injury is acute, whether it's chronic, they're all going to get the same 24 visits, the same 3 therapies up front for the first 12, the same 2 therapies up front for the last 12. And if we were to review your records, would we look at the last 100 patients you had and say that there is a definite pattern of treatment that isn't necessarily substantiated by any defined standard of care? And then do I demonstrate the impossible day, which we'll talk about in a little bit. So if you do answer yes to any of these questions, then you have to ask why. And if the reason why in any way, shape, or form incorporates something like, well, that's what I need to say to get paid, or they won't pay me otherwise if I don't do it that way, that's when the problem starts coming in. So medical necessity. When we deal with medical necessity, Paul had alluded to it earlier, you have to recognize that there are many different definitions for medical necessity. And there may be one that you have to deal with and live with that are defined by the insurer. Obviously, Medicare's definition of medical necessity may be very different than what we consider to be medically necessary. But in general, they're medical services that a contracted provider provides to a patient. So basically, you are providing a health care service to somebody. You must use prudent clinical judgment. And again, you must be able to justify what you do. It must be documented that you justify what you do. It has to be in accordance with generally accepted standards. And this is where chiropractic, unfortunately, has a problem because we really don't have a defined standard of care. We have a lot of different opinions and we have a lot of different ways of doing things, but there is no actual one way to do it. So we have to make sure that whatever you do in your office, there is a clinical rationale for it that can be substantiated by some credible source. Must be clinically appropriate, obviously, and that makes sense. And it's not for the convenience of the patient. So I'm not going to see you 3 times this week and only once next week when I want to see you 3 times a week. The idea here is that you treat the condition, but you don't treat the patient's schedule.
So when we look at unbundling, so if you require a patient to return to the office, let's say on a different day to perform a service that would otherwise be covered or covered at a higher rate or duplicative or bundled, is there a clinical rationale documented as to why they came back the next day for a service that you know if you had billed it out, it would have been bundled, let's say, with an E&M service? If the answer is the only reason they came back is so you can get paid, then you run into a problem. Evaluation of management services. When we look at E&M components, new or established, there are multiple components to document for an evaluation or management or an exam, and those that you see here are included in that. And oftentimes what we'll see is on re-exams, which are evaluation and management services, which require all the components that you see here. Typically, you might only see, we've seen only in re-exams, objective findings repeated, and then perhaps an updated treatment plan, occasionally diagnosis updated, but not always. And so remember that E&M components are required for any exam you bill, even if they're unremarkable since the last time you reviewed or had the exam. And if you're notating positives on objective findings in an exam, please repeat those objective exams to see if any of the positives have now been resolved. When we look at E&M, again, 9920 and then the level of new or established, oftentimes we'll see providers dictate the level of exam based on how much time they spent with that patient rather than the components in the E&M guidelines set out by CMS. So time is not an overriding factor in an E&M level. It is the amount of documentation that you provide based on chief complaints, the history, past family and social history, the objective findings, how many organ systems you reviewed and how many components within each organ system were reviewed, and then medical decision-making and what complexity of medical decision-making there was to help achieve the level of exam that you may bill out.
If we look at the E&M services again, you can see that one of the things that has been an issue in the past, doctors would bill an E&M service with the chiropractic adjustment on every visit. So they do this very low-level, brief exam type of situation, and they would bill it with the chiropractic adjustment. And that's improper because the CMT code itself already includes what they consider enough examination procedure to determine what to adjust and where to adjust and how to adjust the adjustment itself, and also the post-assessment of the effectiveness of that adjustment. And that's all bundled into the 19894 1 and 2 codes and 3. So you shouldn't be billing an E&M service on every encounter with your chiropractic adjustment. A lot of times you might see billing an E&M in place of a CMT because they'll say, well, they only have 12 adjustments, but they have unlimited exams. So again, ask yourself the question, why am I doing that? I'm doing that to get paid. Boom, you just crossed the threshold into a fraud situation possibly. Using a new patient exam code in the 3-year rule. Now, most of the time, honestly, we know this is just an error. This is just a mistake. But sometimes you might see a new patient exam code being used in a situation where a patient in a personal injury scenario, the patient had seen you 6 months prior for a different accident, and all of a sudden the attorney asks you to just bill it as a new patient code because you don't want to alert the insurance company that they've had a previous accident. Again, simple question, why am I doing it? I'm doing it to get paid. I'm doing it to get paid better. I'm doing it to avoid any hassle. All those reasons bring you into the possible fraud category. And then if you code at the higher level based on time, and Paul had mentioned this, that code, E&M code, is not a time-based service. Now, we know when you open up the book, it puts time next to it, but that is not the threshold. If we look at, like, for example, a 99204, which is a very common code that we see in the chiropractic world, but when you break it down, you dissect out the descriptions of this code, you can see that on most occasions, and I mean 98% plus occasions, we do not hit the threshold to bill a 99204, even though we might spend 45 minutes. So if you look at like presenting problem of moderate to high severity and read the definitions of moderate to high severity, and the key here happens to be, problem with risk of morbidity, disease without the treatment, we might say, yeah, possibly, and that risk is moderate, but is there a moderate risk of death without treatment? We don't really hit that threshold, let alone a severe to moderate to high risk of death. So we really don't hit that first threshold right there. It requires a comprehensive history, and I mean a comprehensive history. So you have to go back and do family, social history, systems reviews, all of that. And again, often the code, the notes that we see don't hit that level of history taking, as well as a comprehensive exam for the same rationale. And then it must have moderate complexity medical decision making. It's making multiple number of diagnoses or management options, moderate data to be reviewed, low risk of significant complications or morbidity and or mortality. So when you look at that, you go, wait a minute, no, we have all these different segments of the spine, and I have to determine which one is subluxated and needs to be adjusted. And yes, and that's rational. That's a logical conclusion to how to apply this to our profession. But even if you hit the moderate complexity medical decision-making threshold, which is not really likely, but even if you did, the others definitely eliminate the use of this code. And yet, this is a code that's commonly presented out in the billing world because you think of it and say, I spend 4 or 5 minutes. So, chiropractic codes in question. So when we look at the code, the spinal manipulation code, it's based on areas treated. So we have 98940, 1 and 2. So the 1 to 2 areas, the 3 to 4, and then the 5 areas. It's specific locations. It must be specific, and it must be specific to the diagnosis code. So you don't just adjust all these segments and you don't have a supporting diagnosis or a reason to treat that area. And we know that a lot of times the technique used might involve in adjusting areas that are not necessarily symptomatic, but that doesn't mean you don't diagnose some level of segmental dysfunction or subluxation in those areas. And your SOAP note must correlate with all of it. So you must have your subjective must also align with your objective. So if I'm going to have a complaint and I'm going to have 3 areas that I adjust, you may not always have 3 areas of symptoms, because we know chiropractic that you can adjust areas that aren't symptomatic, but insurers don't necessarily understand that very well. So they're going to be looking for a subjective to correlate with every area you adjust. But at the very least, you need your objective. You need to have clinical reasons why you're adjusting those areas. And, of course, your diagnosis and then your plan. And just as a reminder, we talked about what the 5 spinal regions are. And you can see that as silly as it is, it's still pelvis, which includes the sacroiliac joint, is a separate area than the sacrum. As a clinician, I can never reconcile that. So,
when we take a look at the 98943, which is the extra spinal, again, this should only be billed if you have the SOAP in place in your documentation, and it is 1+ region, so it doesn't matter how many extra spinal or extremity areas you adjust. It's 1 unit billed for that day, not multiple units. And again, it should all correlate back to chief complaint, your SOAP, your metrics, you name it. And the 5 extra spinal regions are listed as such, and you can see them there.
And Paul had mentioned previously, you cannot use your technique as a justification for billing for an extremity adjustment. That's not to say that you don't perform the service, but the SOAP must be in line and justify the adjustment to the extremity, and it must be a reason other than it's the protocol of your technique.
When we look at time codes in question, and these are time-based codes, condition-specific, it's not maintenance or supportive in care. Defining metrics, that's usually where a lot of providers fall up short, is they use a time-based code and there is no metric to measure the success or if there's improvement or not with the service being delivered. Will achieve corrective benefits in a reasonable period of time. Oftentimes we'll see that, a personal injury or an auto case where the diagnoses and the progress isn't documented till the last visit, and so it could be 3 or 4 months later, and all of a sudden everything resolves on the last visit, where realistically, from progress exam to progress exam, we would consider seeing diagnosis start to fall off the bill as resolution happens for certain conditions. Your short-term goals and your long-term goals reflect the functional improvement. Again, you're going to have, your metrics, and then you're going to have your goals, and as they are achieved, they're noted or documented until you achieve the results you're looking for. And the plan of care updated as patient's condition changes, and obviously would be, reasonable to see less visits over time as patients improve, and maybe home care exercises or programs are also recommended and delineated out there.
Make sure you stay focused on the corrective aspect of your treatment when it comes to insurers. Even though there are a lot of services we might provide a patient that are good for the patient. Every patient needs exercise. Every patient might need certain types of services that we provide. It's important that you relate them directly to the subjective and the objective and the assessment portions of the note, because that's how insurers judge whether or not to pay you. So if we look at manual therapy, electrical stimulation, if we look at electrical stimulation 97032, this is an attended service, which means you have to be there. It is time-based, so it's performed for 15 minutes, so it is a time-based code, and it's one-on-one. It's impossible to do a constant attendance without somebody standing there one-on-one. You could use the 52 modifier, which means reduced service, but that wouldn't be appropriate if the service was less than 8 minutes. So basically, when you add the 52 modifier, you're saying I did it less than 15 minutes, but I also did it more than the 8-minute threshold, which is necessary for them to consider that the service has been done effectively. So you could use the 52 modifier after the CPT code as long as it's after 8 minutes, but less than 15. And it's regardless of the areas being treated. It's the one time. The units are based on the one time, on the time itself. So one unit, no matter how many areas you treat, would be for the first 15 minutes. And then if you did it the second 15 minutes, you could bill it again. The manual components, this is the thing. This is the difference. Attended electrical stim does not mean I put the pads there, sat there, and talked about the World Series. That's not what it means. It actually means that there's this active dynamic treatment taking place, usually with a device like a wand. A lot of times people might deliver electrical stimulation through their ultrasound head, but it is not the pads sitting on the patient and then you move the pads from the shoulders to the mid-back, from the mid-back to the low back. That is still unattended electrical stim. So a lot of times this is where people will create a problem, and the difference here is a lot of you'll say, well, why are you billing 97032 instead of billing the unattended electrical stim code? And the answer might be, well, they don't cover the unattended, but they cover the attended. And that's where it starts getting a little bit tricky. So the question is, do you intentionally do this? You call unattended attended. You perform it less than 8 minutes, but yet you still bill. It's performed by an assistant when your state doesn't allow that, because it is a constant attendance one-on-one code. You have to be, you have to make sure that your state allows assistants to perform that service. And it's not performed one-on-one. Again, you put the pads on, walk away, and call it something else. And you're not charging the patient the same for that service, the self-pay patient the same as you would for an insurer. And again, that brings us back to the ChiroUSA discussion. So therapeutic procedures. Okay, so therapeutic procedures, again, are time procedures. They're 97110 to 97140. They encompass all of those timed-based procedure codes. They are defined by an improvement in function, not by pain. So you wouldn't do therapeutic exercise to get rid of pain. You have to do therapeutic exercise for one of the reasons why, which we'll talk about in a minute, that you would do therapeutic exercise for. So it is about function when it comes to therapeutic procedures, not symptom. Again, it's direct one-on-one contact, and it's regardless of the regions being treated, it's a time-based code. Okay, so therapeutic exercise. Therapeutic exercises, it's a therapeutic procedure. It is timed-based one-on-one. So that requires you to perform that service for 15 minutes, a minimum of 8 minutes for the first unit, which is the 8-minute rule, correct? But there has to be somebody there. It's not, you don't hand them a sheet of exercises or tell them to do 12 reps and walk away. This is skilled service where somebody is standing there one-on-one. So if you represent this code on a claim and it is not performed one-on-one, then you are billing for a service that was not provided, because they expect, by the use of this code, they expect that someone was standing there guiding them through the exercises. It's regardless of the regions being treated. Again, the units are based on time. The clinical rationale and metrics need to be documented. So your rationale has to be for one of the 4 reasons why you perform therapeutic exercise, which is develop strength, endurance, range of motion, or flexibility. So again, not for pain. It has to be one of those reasons. And you have to have a metric to gauge whether or not their strength is getting, is the patient getting stronger? Does the patient have more endurance? Is there a greater range of motion or flexibility? They're not interchangeable with neuromuscular reeducation, 97112, or massage services, which is 97124. It's not an interchangeable code. The reasons for doing one or the other are different. And you don't use a 52 modifier. You cannot use a 52 modifier to indicate that you did less than the required time.
So when you look at and asking yourself with therapeutic exercise, do I intentionally perform less than 8 minutes for the first unit and bill it out? Is it just for symptom relief rather than the clinical rationale set out in the definition of the code? Do I have no metrics to measure the performance or outcomes of therapeutic exercise? Are you allowing an assistant or clinical assistant to perform the one-on-one component, but it's not within the jurisdiction or your jurisdiction or state law? Not one-on-one at all? Or are you not charging self-pay patients for the same service you'd charge to an insurance carrier?
One thing you have to be careful is if you're going to perform a therapeutic exercise service, you have to have a reason for doing it. That reason must be linked to the reason why the patient is there, not that exercise is just good for you. We know that. And the insurance company would expect you to hand your patients home exercise programs to try and improve all these areas. But if you're going to bill them for this skilled service, then it must be directly linked to the symptom and objective findings and the diagnosis of the patient. And if you put this code or any code on a claim form, you are attesting that that code is the truth. And you are literally swearing to the insurance company that this is the truth. So neuromuscular re-education, again, it's another time-based code. It's a therapeutic procedure. It's time-based and it's one-on-one. So it isn't one of those things where you just say, give me 12 and you walk away. It's nothing like that, okay? It is done for the re-education of movement, balance, coordination, kinesthetic sense, posture, and or proprioception for sitting and or standing activities. So if the patient comes into your office and says, I have low back pain, it doesn't fit one of these reasons why you would perform neuromuscular re-education. Truth of the matter is this code was developed as a stroke rehabilitation code, and then all of a sudden these definitions make a little more sense. We can broadly interpret them into the chiropractic model if we're talking about core strength, but again, you also have to relate the weakness of that core to the condition for which that patient enters your office. So it's very important. There was one question over there that the ART technique, this actually falls under neuromuscular re-education, but be very careful in the fact that you have to have a reason for doing it, and that reason has to be directly related to the subjective and objective findings of the patient. You can't use a 52 modifier. It doesn't matter how many units. It's all based on time. Again, the same thing. Metrics, metrics, and metrics. And they must be documented. So if the patient came in and said they had a balance problem, you have to have a way of measuring whether or not your services are improving that patient's deficiency. So metrics, metrics, metrics. And it's not interchangeable with muscular re-education, with therapeutic exercise, massage, or manual therapy. So if you're performing this service and you do it intentionally less than 8 minutes, then that might be considered a reason why it's fraud. If you perform it for symptom relief or for other reasons like therapeutic exercise, I'm doing it to improve their strength. Well, neuromuscular re-education, one of the reasons for doing it is not strength. That would be therapeutic exercise. No metrics. It's performed by an assistant when the state does not allow assistants to perform one-on-one services. That's very important because, again, the code says it's one-on-one. And you're charging differently for your self-pay services than the same service to insurers.
So let's take a look at 97140, manual therapy techniques. This is a time-based code and one-on-one requirement. You should not report the 52 modifier in any circumstance, because if you are performing less than the time required, it is not a billable code. The units are time-based, so regardless of how many areas you may perform, the units that you bill out are based on the time component themselves. If you're performing manual therapy techniques in lieu of the chiropractic adjustment, then you would require specific documentation for the rationale. We have seen in some instances where provider offices would not adjust a certain area of the spine just so they can bill the manual therapy technique, yet they had objective findings and indications that a chiropractic adjustment was indicated or would be the preferred service, yet they consistently don't do that, knowing that there is an anatomical site restriction to this code, which is the bottom point in red, that if you are adjusting in any of the regions using a CMT code, even if you perform the manual therapy for the full time required, it is not a billable code. They consider it a redundant service and bundled. So keep that in mind, that if you are going to do manual therapy techniques on an area, that you should document why that is the preferred service over the chiropractic manipulation therapy. These are not interchangeable codes as well. If you are doing massage, that is 97124. If you're doing neuromuscular reeducation, that's 97112. And keep in mind that massage does not have an anatomical site restriction as opposed to manual therapy techniques. So, ask yourself, are you performing manual therapy techniques on an area that you're adjusting with the chiropractic adjustment? And if so, the manual therapy should not appear on the bill. Are you routinely finding that an area of the spine that requires manual therapy never needs to be adjusted? Again, that could be an indicator or a red flag. Diagnosing segmental dysfunction or subluxation and not adjusting in order to perform manual therapy. And services performed are less than the required time. Again, you cannot use a 52 modifier on this code to bill out for less than the required unit of 15 minutes. And are you not finding or charging a self-pay patient for the same service that you are for the insurance carriers?
This particular code is probably the most problematic of all of them in that if they are going to accuse you of fraud, it's going to be this code somewhere along the line. Because routinely we would see that a doctor commonly would adjust two areas of the spine and do manual therapy on the third. And you ask them why they're doing that, and then the reason comes out to be, well, I can't adjust that area or they won't pay for the manual therapy. Or they might actually diagnose subluxation in that third area and still not adjust it, which, again, the adjustment would be the preferred service to provide to that area, yet you don't provide it. You've actually diagnosed it, but you're performing manual therapy. And again, the reason for it is that I want to get paid for the manual therapy. So always ask yourself the question why, and if it comes back to the money issue, that's where you're walking on thin ice. So, modifiers. Modifiers, again, you could misuse a modifier. Medicare, you're going to use an AT modifier to indicate that it's active treatment when indeed it is maintenance. And that has been Medicare's biggest issue, that what they consider maintenance is different than what you might consider maintenance. And the bottom line is that there's been no demonstration of functional improvement through the use of outcome assessment tools. So whether you like it or not, if the patient is maintenance, they are maintenance. You might be billing without a signed ABN. So use the GA modifier to indicate that you have a signed advanced beneficiary notice, telling the patient that they may be responsible for those services. And yet the patient, again, that's misleading the patient into thinking that they're going to receive reimbursement from CMS, from Medicare. Dash 25 modifier, we've seen a lot of this across the country recently where you would normally add this modifier to an A&M service if you intended to adjust on the same day because it is a separate and distinct service. But you wouldn't use this with using what we said earlier about using A&M services on every encounter, just so that you could, in a sense, increase the bill. We've talked extensively about the 52 modifier, where it's a reduced service if it's less than 8 minutes, or a therapeutic exercise, a therapeutic procedure, you cannot use the 52 modifier. And then the 59, which is billing separate and distinct service when it is not. You build 97140, you put the 59 modifier on it, indicating that you are aware that the area you treated is a separate and distinct area from that which needed an adjustment. So by putting these codes and modifiers on a piece of paper and sending them to the insurer, you've pretty much attested to the insurer that these things are real. And then this pattern, formulaic treatment, I alluded to it earlier. Everybody gets the same thing. And the bottom line here is, a 20-year-old is going to heal more quickly than an 80-year-old. 3 problems should take longer to treat and heal than 2 or 1. Getting in an automobile accident should require more treatment than someone who just had a little bit of a hitch in their get-along, so to speak. But yet, when you review all your treatment, you find out that the first 12, everybody gets this, the next 12, everybody gets that, and then the next 10, everybody gets this. And it doesn't matter what's going on with that patient. And then finally, to dream the impossible dream. Does everybody, if you were to add up all of your time, because they're time-based codes, you were to add up all of your time, does it exceed 24 hours a day? Here's the math. 40 patients, for example, receive a chiropractic adjustment with manual therapy. Assuming you can do a chiropractic adjustment plus documentation in 3 minutes today, that'd be very good. 1 unit of manual therapy or therapeutic exercise for a minimum of 8 minutes. That's total per patient, 11 minutes times 40. That's 440 minutes divided by 60 per hour. That's 7.3 hours of actual treatment time. And if you add in a second unit, there you are. Boom. You're at 17 hours of treatment time. And they know this. Their computers spit this out. So, and that's their new term now, the impossible day. Are you performing an impossible day?
So the fixed checklist, let's talk about if any of these things are hitting a chord as you are hearing this now or if you're listening to it later. Know your contracts with your insurance carriers, but treat the patient, not the coverage. I always say when I'm in a seminar and I get asked the question from a staff person or a doctor and says, how many therapies can I do on a patient with this insurance? I always say, you need to treat the patient and not the claim. What does the patient need? It's about what is the clinically indicated for a patient, and then once you have that, you can package it in the best claim scenario you can, but it always has to be starting with the patient first. Complete all the forms. Don't leave blanks. If you consistently have paperwork that there's constantly the same fields are empty or blank, typically maybe it's a witness to a consent to treat, or it's a patient countersigning a verification, things like that, is to tighten up the office procedures by either insisting that those things get done, or if it's a data element that you just don't need, take it off your form so it's not a blank, so it doesn't look incomplete. And if it's something that you want to keep but rarely gets asked, put an NA or a dash or something to indicate that particular data element was addressed but not needed. Know your codes. Of course, taking seminars, webinars, getting the AMA, CPT, and ICD-10 code books each year is really a necessity. They do get updated annually. Sometimes it's a definition or a specific clinical scenario that updates. ICD-10s will update in October each year. That will go into effect as of that time going forward. So any good compliance program is going to have a requirement of the updated coding and reference books that you would use in your office. Exam to re-exam must make sense. Again, we talked about this where if you're doing an exam and you have positive findings in your objectives and then you don't repeat them, how significant were the positive findings? Most likely those things have resolved, but it's just documenting it from exam to exam so that you can see in the Cliff Notes version of CARE, which would be progress note to progress note, that things are improving. The SOAP must support each other section and from section to section and day to day so that if someone's reporting a subjective finding, you have an objective review, you have an assessment, diagnosis, and a plan of care for that, and that each section makes sense and they correlate, and then from day to day things correlate, so that if you were to take the names off of 2 different SOAP notes, does this look like 2 different patients or 2 different visits that don't correlate at all? Someone may walk in with something brand new or an exacerbation of something that had resolved, no problem, then obviously that dictates some type of an E&M service to move forward on that. And we're just asking that the story makes sense. Tell the story from beginning, middle, and end. Just talked about that, so the whole thing threads through. And the end is really the emphasis here. Is that the end could simply be that they've reached a medical endpoint or a chiropractic endpoint with respect to that third-party coverage, but you want to see them on a maintenance care. Fine, then there's an end to this particular care and on to maintenance. But at some point, there needs to be some type of an end to that particular care, and then on to maintenance if that's your flavor of practice, no problem. Define your procedures, protocols, and record it in your compliance manual. Here's where obviously services like ours would come into play to assist you, but you need to have defined procedures and protocols. And if you already have something, you have a compliance manual on the shelf, pull it down and take a look at it. Oftentimes we'll see these compliance manuals that were made a while back and really never updated or never really reviewed. They often include procedures or protocols that you don't even do. We've seen ones that have like mobile X-ray, and then we ask, "Where's your mobile X-ray?" And they say, "Well, I don't have that. I never have." But the compliance manual they purchased from somewhere says that type of thing. So review your procedures and protocols. Make sure that what's in your compliance program is what you do, and if you do change things over time, is update that to reflect what you're doing. Use the pyramid approach: frequency, type, duration. Again, there should be a winding down or resolution to patient's issues, and if not, then a referral out if they aren't resolving with the care that you're delivering. There could be something additional there to look at, so that there is a cycle down of care where they hopefully move into resolution, pre-injury status, MMI, and then on to maintenance, and they're with you for the chiropractic maintenance aspects of care. Dr. Davini already went through this quite a bit, where you do not treat all the patients the same. If you were to take 5 records, remove any identifiers, do they all look like the same patient, even though one's a 18-year-old kid playing sports, another one is a 40-year-old who's out of shape, and a 75-year-old who's got all kinds of significant medical history, and they all read and look the same? Is there uniqueness enough where the care is specific and defined for that particular patient's medical history and conditions? Clear short-term goals, long-term goals with progress updates using outcome assessment tools and metrics. So here's where we see a lot of deficiencies, oftentimes maybe less so in Medicare with PQRS and G codes, but having those goals where there's documented metrics to achieve certain progresses throughout care, hitting those goals, and moving forward to, again, some type of an end. Be careful of that same as last time or recreate button. We're not suggesting you don't use your EHR software to its fullest, and that can certainly be something that as you get into and understand and use your EHR more and more, you can find ways as you get to know it better to really use the power of your EHR software to your advantage. But at the end of the day, if you're using a same as last time button and it's copying over the SOAP, diagnosis, and CPT codes for treatment, are those all accurate in painting the picture that you want, so that it doesn't look like from day to day to day it is the same thing over and over again? And then document. That's the end of the day. That's where it comes down to is oftentimes you're doing these things, you're just not putting it down on paper. So after the fact, 3 months, 6 months, a year, 2 years later on an audit, that's not where it's going to help you. It's documenting at that time. So we'll take a look at some questions now.
Yeah. There's one quick one I can answer. Somebody asked a question about the pelvis being 2 areas, if you include the sacrum. The way it works is the pelvis is the sacroiliac joints, really. So if you're adjusting the sacroiliac joint, you cannot count that as an adjustment to the pelvis and the sacrum. That's the stupidity of it. We didn't make it up. That's just the way it is. So if you're going to adjust 2 areas, you must show adjustments to both the sacroiliac joint, for example, and the sacrum. So you might have a sacroiliac joint adjustment and a base posterior sacrum or sacral left or whatever, but they have to have two separate adjustments and listed separately.
So the question about self-pay, I mean, ChiroHealthUSA is really your answer to making all things compliant. So certainly a time of service discount is something you can do, but ChiroHealthUSA makes a great, they provide a great opportunity to let you do the things you want to do in a compliant way with the service they provide. Question about 97140, and instead of repeating the entire question, I'll give you a summary. The question was basically, if I'm going to do a 97140 manual therapy technique in addition to a chiropractic manipulative therapy, and I'm doing a chiropractic adjustment to the cervical and thoracic regions, can I do manual therapy on a shoulder that articulates with the cervical and or thoracic, and can I get reimbursed? So the question really is connecting it back. Is there a
shoulder problem? Yeah.
Yeah. If the shoulder, if there's a shoulder complaint, chief complaint of a shoulder, diagnosis of a shoulder, manual therapy on the shoulder, documented.
Objective findings of the shoulder.
Yeah.
Yeah. Not just because treating the muscles of the shoulder is good for the mid-back. There's a difference there.
I think Dr. Davini answered the active release technique CPT code question, but I'm not sure.
Oh, yes, they did. That's more in the neuromuscular education realm. So, okay, so I want to thank you very much for your time and attention. There was a lot of information there. We'll be happy to follow up with any questions that come in after the fact, and we appreciate your time. We appreciate ChiroUSA for giving us the opportunity, and in particular, Christy for all her work in making this possible.
Well, thank y'all for being here today.
Thanks, Christy. And if anyone needs to get a hold of us,
thank you.
I'm sure they can find us through Christy or through the web.
Absolutely. I do encourage you to visit their website, toolsofpractice.com, and reach out at sales@toolsofpractice.com. This was a lot of information that we went through very quickly. Your webinar recording will be ready in about 15-20 minutes. You'll get that email with the link to go back and watch it. I encourage you to watch it again. A lot of information, a lot of great questions too, which is why we took a few minutes over the time allowed to answer those. And again, if you think of more questions, email Paul, email Dr. Davini, send them your questions in the next day or two when you're watching this recording. If you're the doctor, you need to be sharing this information with your office manager and your billing and insurance staff. Hands down, they need to know this. Billing and insurance staff, office manager, if you're watching this, your doctor needs to know this information as well. Share it with them. Make this part of your team training. Make it the focus of one of your staff meetings. This is very, very, very important. And compliance is everyone's responsibility in the practice. Paul, Dr. Davini, do you have any closing remarks?
Again, I'd like to thank you for this opportunity. If you have any questions concerning this information regarding compliance, please contact us through sales@toolsofpractice.com, and especially look into our remote compliance officer assistant program. We feel it's very unique and something that has been very successful and universally appreciated across the country. Thank you.
Huge thank you to Christy and ChiroHealthUSA for giving us the opportunity, and we look forward to the opportunity in the future.
Absolutely. Thank y'all, everyone, for being here today. Just a reminder, next week we have When to Find and Consult with a Chiropractic Neurologist with Drs. Bryce Jackson and Daniel Lane. The following week, we pick back up with our CA monthly webinar on the 2018 OIG Chiropractic Portfolio to Manage Your Risks. And because now everything has been fixed with Citrix GoToWebinar and GoToWebcast, we have rescheduled the ChiroHealth, how to properly set up your ChiroHealthUSA fees in ChiroTouch software for all of our ChiroTouch users. That has been rescheduled for June the 14th, 2018 at 1:30 p.m. Eastern Time. So you do not have to watch it live. You can register for the recording, and we will send that to you. But I just wanted to let you know that since that poor webinar was being scheduled during the technological downtime during GoTo webinars, all their issues that they were having. Anyway, it's been rescheduled. It's on the books. Put it on your calendar. Register if you have not, and you're using both of our using ChiroHealthUSA and have ChiroTouch software. We look forward to seeing you again next week. Gentlemen, have an amazing rest of your day and a fabulous week. We look forward to seeing you all again soon.
Thank you.
Bye, everyone.
Thank you.